Assalamualaikum and good morning to all our viewers. Welcome to the National Institute of Health Continuous Medical Education CME Session 2024, organized and brought to you by Sector for Health for Research Information Resources, NIH. We are now live from NIH Studio Setia Alam and also via our YouTube channel, NIH Ministry of Health Malaysia. So today is another series of NIH CME for this year, and this is a platform for NIH researchers to share their findings and experiences with others, particularly to public. So together with us today, we have a very special guest on board, Dr. Farhana Aminuddin. But before we proceed, take a look at this promotional video.
We understand that healthcare is not just a word, it is a way of life. A health system consists of all organizations, people, and actions whose primary intent is to promote, restore, or maintain health. Like any other system, it is a set of interconnected parts that functions together to be effective. Health systems research provides scientific evidence to policymakers and health managers to enable evidence-based decision-making. At the Institute for Health Systems Research Malaysia, IHSR, we believe that research is the key to improving health systems and healthcare delivery, which is at the very heart of improving the health of the population. We are a group of multidisciplinary researchers who aim to provide evidence to health managers and policymakers at all levels. Our aspirations fall into 4 pillars: enhance our capacity and capability in health systems research, strengthen our alliance with local and international partners, promote and advocate translation of knowledge, promote research uptake. IHSR has 6 centers: Center for Health Outcomes Research, Center for Health Equity Research, Center for Healthcare Quality Research, Center for Health Economics Research, Center for Health Policy Research, Center for Health Services Research. We conduct research for evidence-based policy, continual learning, and consultancy to achieve the aspiration of the Ministry of Health, a nation working together for better health. Let's deep dive into the 3 core aspects to understand further. In research, we collaborate with our stakeholders to improve quality and deliver more equitable healthcare services for the attainment of better population health. We conduct research methodology continual learning program to a diverse range of health professionals. We have trained healthcare professionals and support staff in health policy and systems research. We provide consultancy by our subject matter experts, including research methodology and technical advice at local and international level. Let us go deeper into the past and present work, be it locally and globally. We advocate for health system strengthening. Our research area revolves around WHO health system building blocks. Here are some of our research examples. Through our continual learning, we are able to continuously build competency and capacity in research and quality assurance, quality improvement, empowering others to strengthen the health systems. In our core aspect of consultancy, we can see our achievements clearer within our various on-the-ground consultancy services, where we go to different stakeholders and practitioners in the healthcare system. We aspire to continuously build capacity in health policy and systems research, and taking evidence further. A well-functioning health system working in harmony is built on having trained and motivated health workers, well-maintained infrastructure, and a reliable supply of medicines and technologies, backed by adequate funding, strong health plans, and evidence-based policies. We open our doors to any fellow collaborators from all over the region and world to partner with us as we bring the Malaysian healthcare system to the next level. Because health should be something which does not see borders or geographical lines. Health is for everyone.
Welcome back. Just a quick reminder for all our viewers today, do register yourself at the link provided in the description section, and please respond in the link also if you have any question to ask for our CME session this time. All right. Just take a break. All right. Let me give you a brief introduction to our speaker today. I have Dr. Farhana Aminuddin together with me, and she is currently a research officer from Center for Health Economics, Institute for Health System Research, IHSR, National Institute of Health, Ministry of Health, Malaysia. As a junior officer with over 5 years of dedicated service, she is on a promising path towards making significant contributions to the field of health economics. At the Center of Health Economics Research, Dr. Farhana is involved in research focused on health economic evaluations, including cost-effectiveness analysis, cost-benefit analysis, budget impact analysis, and healthcare efficiency. So in short, she's the rising star in her own area of interest. Okay, so currently Dr. Farhana is working on a groundbreaking project aimed at understanding the financial burden faced by cancer patients. Her research delves into costs incurred by these patients, the loss of productivity, catastrophic expenditure, and the resulting impoverishment. We are privileged to have Dr. Farhana with us today to share her insights and findings. So please join me to welcome Dr. Farhana.
Right. Thank you, our moderator, Eliana, for a short and nice introduction of me. Assalamualaikum warahmatullahi wabarakatuh. A very good morning to everyone. Once again, I'm Farhana from the Center of Health Economics Research, IHSR. So I am delighted to present and sharing findings of my currently completed project on the financial burden of cancer. I hope this presentation will provide comprehensive or better understanding on the financial burden of cancer, and also the broader socioeconomic implications from the lens of patients. So here's the content of this presentation. I skipped it. So first of all, I would like to extend my sincere thanks to these amazing and important people towards the completion of this study. First of all, our stakeholders, Planning Division, Ministry of Health, and also the Protect Health Corporation. Our project team members from Center of Health Economics Research, also colleagues from IHSR. We also have colleagues from the Planning Division, also the oncology specialists from Hospital Kuala Lumpur, as well as our research assistants who collect the data. And also the funder for this study is the MOH research grant. All the study sites involved in this study who cooperated during our study data collection, as well as our study participants, all the cancer patients who have consented to be part of this study. All right, so we begin with the study overview. This study was commissioned by stakeholders, which was first conducted as a pilot and feasibility study, was in 2021. Later on, following this, we have conducted the large-scale study between 2022 and 2023. So this study was a part of a larger evaluation study on the PICA B40 program, with the focus on the financial incentives within this program, which are the completing cancer treatment incentive as well as this transport incentive. So this study was, the findings was presented to the stakeholders last year, and several outputs were released and published, including research highlights, infographics, and also manuscript. Coming up, the technical report, as well as few manuscripts in planning. And little bit of disclaimer regarding this study is that this study only covers the target population of the lower income group, which is the bottom 40% of the population in Malaysia, having or living with cancer and eligible for PKB40. So we're afraid that the results or the findings of this study could not unable to be generalized to the wider population in Malaysia. So cancer, I think everyone knows that it is a major disease affecting the world. It still remains as the second leading cause of death. And in 2022, close to 20 million new cancer cases was reported. And in Malaysia itself, over 51,000 new cancer cases was recorded. So battling the cancer alone is a journey full of emotional and physical struggles. In addition to that, it is even worse and challenging for financial difficulties. And so the concept of the financial burden of cancer covers both direct and indirect costs, which has a significant impact on individuals, patients and their families, as well as communities, societies, as well as a health system of a country. So for lower income group in Malaysia, which is the bottom 40% of the population in Malaysia, they are at higher risk of experiencing the financial burden. And given that in Malaysia, although the charges imposed at public facilities were very minimal and almost fully subsidized, a local study had reported that close to 50% of cancer patients still face a financial catastrophe within a year after they have been diagnosed with cancer. So financial challenges or crises due to cancer is not just theoretical. They are widely known and also highlighted in the media. So we can see these are few examples from the news headlines showing the financial crisis faced by cancer patients and their families. So I would like to bring to you some of the examples. A recent interview from the Dayak Sarawak newspaper. They had interviewed the consultant hematologist Dr. Chu Liping from the Hospital Umum Sarawak, whereby Dr. Chu had mentioned and shared that many of her cancer patients did not turn up for appointments, and the most common difficulties is the fear of losing income experienced by patients and their caregivers. And for elderly cancer patients, they decided to forego the treatment rather than create or place a burden on their child. And another important point from the interviewed is that the transportation is very expensive as shared by her cancer patients. So these are real situations that faced by cancer patients, especially for those with limited income. So we can see that from this evidence, cancer is cruel, but combined with the current cost of living, it is even utterly dreadful. And in addition to the government subsidies provided, our Malaysia government under the Ministry of Health introducing a health scheme known as PKB40, which is aimed to sustain the healthcare needs of the bottom 40% of population. So those eligible are the bottom 40% of the population, or known as B40. They are receiving the government aids, Sumbangan Tunai Rahmah, must be aged 40 years and above. And for cancer patients, they are actually benefiting 2/4 of the PKB40 benefits, which are the completing cancer treatment incentive. From this incentive, a maximum of 1,000 ringgit Malaysia can be credited to the cancer patients who are eligible for this scheme, and disbursed in 2 separate payments. The initial 300 is given. The initial of 300 ringgit is given into their account at the outset of the treatment, and the remaining 700 ringgit is given after they have completed or attended at least 2 medical appointments within the 9-month periods. And the other benefits that they could get is the transport incentive. For Peninsular Malaysia, they could get up to 500 ringgit and else the Sabah and Sarawak can have up to 1,000 ringgit Malaysia. So this study explored various components of the financial burden of cancer. So by estimating the cost, and also we assessed the broader socioeconomic implications in the form of catastrophic expenditure and impoverishment, and then we looked at the impact, how does the financial incentives under the PKB40 could help reducing the financial burden faced by cancer patients. So ultimately, this study aimed to provide a comprehensive understanding on the financial challenges faced by cancer patients, and to serve as a basis for supportive policies and interventions in the future. So here's a summary of the study methodology. This study was conducted as a patients. So retrospective primary data was collected through face-to-face interview with the cancer patients. So the setting, all 6 cancer centers under the Ministry of Health included across Malaysia. So we have central region, we have HKL, Hospital Kuala Lumpur, and National Cancer Institute. Northern region, we have Penang General Hospital. Southern Malaysia, we have Sultan Ismail Hospital, Johor Bahru. And then we have from Borneo, we have Hospital Umum Sarawak and Hospital Wanita Kanak-Kanak Sabah in Likas. So the inclusion criteria for the study population are aligning with the PKB40 eligibility. So cancer patients receiving the government aids, the Sumbangan Tunai Rahmah, they must be aged 40 years and above and on active cancer treatment in order to get the expenses on cancer. And then the required sample size in this study with the 10% dropout rate, we have to interview at least 427 cancer patients. And we use the validated questionnaire from our pilot and feasibility study. So we collect the patient profiles, we collect the information on the costs or expenses related to cancer, how they cope with the expenses, the household expenditure, and so on. So the data was collected between June and October in 2022. So these are the core components, the overall core components in this study. So we have cancer-related costs. So we have the direct medical costs first, and then followed by direct non-medical costs. We have indirect costs, also known as the productivity loss cost. And then we looked at the impact due to cancer expenses in a form of catastrophic expenditure and impoverishment. And finally, we looked at the how does PKB40 financial incentive can help reducing the financial burden. So don't worry about all the terms here, because you'll get used to all the terms along the presentation. We'll come back to all the definitions later on. And one more, another term in this study is that we are using the out-of-pocket expenses. So out-of-pocket is the sum of the direct medical costs and direct non-medical costs. In a simple words, the direct cost is also known as the out-of-pocket cost, right? So we come to the findings of the study. All right. Before we go in details, so these are the major 5 main key findings in this study. So first of all, the average total cost of cancer was estimated at around 13,000 ringgit Malaysia per patient per year. So how does cancer patients cope with this 13,000 ringgit Malaysia? So they are experiencing some financial hardship. We can see that 22.3% forced to either borrowings and selling assets to finance their cancer expenses. In terms of the catastrophic expenditure, on average, 31% of the household need to use their available resources to pay for their cancer-related expenses. Furthermore, this study also revealed that 14% of households are impoverished, means that after they make a payment on their out-of-pocket cancer expenses, they fall below the poverty line, meaning that they become in poverty after they make out-of-pocket expenses on cancer. And finally, CCTI or the financial incentives under the PKB40, first CCTI contributes around 18% of the total out-of-pocket cost, and the TI, the transport incentive, contributes around 29.5% for Peninsula and 35.1% for Sabah and Sarawak respectively for the total transport cost. All right. So first, the patient profiles, the socio-demographic. So we had successfully interviewed 430 study participants where all the informations are included in the final analysis. So majority of them were from the age group of 60 to 69 with the mean age of 59.8 years old. And the majority of them, we can see that almost 80% were unemployed during the point of interview, and then from these, about 30.3% were unemployed due to cancer, meaning that they quitting the job after they had been diagnosed with cancer. And then we include all six cancer centers in Malaysia, running through North region, goes to Borneo, and then these all cancer centers serve as a diverse multiracial population in Malaysia, and they provided oncology and radiotherapy services for the patients in their respective region. All right, so in terms of the clinical profiles of the cancer patients, majority of them have been diagnosed with breast cancer, followed by gastrointestinal and respiratory. In terms of cancer stage, at the point of our interview, majority of the cancer patients were at stage 3 and stage 4, with close to more than 75% of them were at later stage. For the current treatment, majority of them were undergoing chemotherapy followed by radiotherapy and a combination of chemo and radiotherapy. And then close to 53% have been diagnosed with cancer just within a year, less than a year, whereas 47% have been diagnosed with cancer over a year. In terms of the inpatient and outpatient visits, the visits made by cancer patients, you can see that in a year they made around 1.7 visits. This is the average per patient. So 1.7 inpatient visits with 10 days been admitted, and also about 10 outpatient visits per year. So now we move to the cost. So first, I would like to explain a bit the definition involved in this cost component. So here's the breakdown. So we can see that from the annual total cost, it comprises of direct and indirect costs. So we first looked at the direct costs. We have the medical, all the money or the money paid for medical bills at hospitals, and then we also have the non-medical, the additional costs which normally are hidden. Normally, people won't realize that there are additional costs related to cancer expenses. So it relates to transport to and from hospitals, and then if you are away from home, they have to pay for food. If their house is further from the hospitals, they have to pay for accommodation and so on. So all this together are considered as the out-of-pocket cost. And then we move to indirect costs, also known as a productivity loss. So we measured in terms of the absent from work, absenteeism. So for employed patients, they have it's almost certain for them to require time off work to get a treatment at hospital. So they must be absent from work. So we value their absenteeism into a monetary value. And also, it is not fair if not include those unemployed productivity loss. So for them, we calculated using limited productive activities. Later on, I'll explain a bit more. All right, so for the total cost, you can see that the average annual total cost per patient is about close to 13,000 ringgit Malaysia. It comprised of the highest contributor is the productivity loss cost, 44%, almost 44%, which translate to 5,600 ringgit, followed by non-medical costs, 29.4%, which translate to close 3,800 ringgit, and finally the medical costs, about 26.7%, which translate to 3,500 ringgit. And in this case, you can see that if we sum the medical and non-medical costs, so we can see that the out-of-pocket expenses is around 7,200 ringgit. So this is what cancer patients spend in a year for them to get treatment. All right. So we go into a cost breakdown. First of all, the direct medical costs. So we can see that the major contributor for the direct medical costs is the inpatient treatment, about 52.4%, followed by 30.3% of the outpatient treatment, and medical supplies, about 17.4%. And it is not shocking. We can see that although they are in the bottom 40% of the population, they might have limited resources. This cancer patient could still or experience getting treatment at private hospitals. So although it is not many, just 39 of them, less than 10%, you can see that they spend more than about over 20,000 a year, which is more than those only going to the public hospitals. In terms of the non-medical costs, so these are the breakdown. So we can see that transport costs is the larger contributor to the non-medical costs, followed by supplemental food, and the rest are quite similar in percentage. And then you can see that there's not much difference between those getting treatment at only public hospitals, or either they go into public and private hospitals for non-medical cost. So in terms of the out-of-pocket, we pull the medical and non-medical costs together. We can see that these three are the notable cost contributor to the total out-of-pocket costs. You can see that inpatient treatment drives the medical component, whereas the transportation and supplemental food drives the non-medical component. All right. So another important point, the travel or transportation cost, because it has been highlighted in many studies, and it is troublesome for cancer patients to spend for transportation costs. So we would like to see the difference between Peninsula and Sabah and Sarawak. So you can see that a single trip made by cancer patients in Peninsula Malaysia is just about 90 kilometers. One single trip, yeah. So and then compared to Sabah and Sarawak, it is 3 times more, with average single return trip is about 261 kilometers. So that's why you can see that, for example, Sarawak is just too huge. Can we imagine those residing at the northern area, how they can find it a bit tedious just to make a trip to Kuching to get a treatment. They might rather go to Kota Kinabalu to get a treatment. So we can see that the annual travel cost for those Sabah and Sarawak is higher, 2,254 ringgit, compared to Peninsula is about 1,500 ringgit. So what's inclusive in the transport cost? So we have we asked about the details of the transport costs. So, for example, the public transport, you can see Sabah and Sarawak is higher than Peninsula. Similar to petrol, you can see that it's significantly higher for Sabah and Sarawak compared to Peninsula. For toll, there's no reported toll for Sabah and Sarawak. And lastly, for the parking fees, no significant difference between Peninsula and Sabah and Sarawak. All right. So now about the productivity loss or indirect costs. So first of all, we have two different groups, but we are not our intention to differentiate between those groups because the majority of our population or study participants are those with no formal job. They are unemployed. Still, they are equally important to include in our calculation. So first, for the employed cancer patient, we use the absenteeism. So it refers, it's actually a simple words. So they absent from work. So what we gather, the information that we gather is their monthly salary, as well as the time of work. So how many days they were absent from work. And then for the unemployed personnel, for example, those are housewives, retirees, as well as those unemployed. So we use limited productive activities. For example, they are unable to perform routine household activities such as to maintain the households, taking care of their child, taking care of their family members, and so on. So in this case, we have calculated that the absenteeism cost is around 15,000 ringgit Malaysia per employed cancer patients per year. Whereas for those unemployed, their productivity loss is about 4,600 ringgit. So again, for the since those unemployed having no formal job and no formal salary, we use the national minimum wage to calculate to put in this calculation. And then the cancer patients were also asked regarding what are the strategies they made in order for them to support or to pay for the out-of-pocket cancer expenses. With the majority of them either use their own income and also the household income, as well as use up their savings, followed by 34.2% receive financial support from non-household members and friends in a form of donation maybe, and then followed by 27.9% rely on financial support from social welfare or NGOs. And you can see that about only 3% of the study participants have the private health insurance. And I would like to highlight these three because out-of-pocket expenses or out-of-pocket payment is an equitable source of financing to pay for the healthcare services. So some of the cancer patients' household in this study were forced to make some sacrifice, financial sacrifice. They have to either borrow from their friends, borrow from their family members, borrow from banks or financial institutions, as well as selling assets just to finance their cancer out-of-pocket expenses. And we can see that about 22.2% of the cancer patient households opt to these three strategies, which puts them even more significant financial hardship. And next, we looked at the catastrophic expenditure and impoverishment. So first of all, the definition, just to make you understand what is the impoverishment and catastrophic expenditure. So first we look at the impoverishment. So in a simple words, before making any payment for cancer out-of-pocket expenses, they stay above the poverty line, and after they make the out-of-pocket cancer expenses, they falls below the poverty, meaning that the impoverishment is a state of becoming poverty. For catastrophic approach, we have it is actually the portion of available resources paid for out-of-pocket expenses of cancer. So in this, for catastrophic, we have the threshold, meaning that the ceiling, the cutoff point at 10%, and also the 25 and 40%. So first we looked at the impoverishment. So to begin with, you can see that even before the cancer patient's household pay for the cancer out-of-pocket expenses, they are actually living below the poverty line, meaning that they are in a state of poverty even before making the expenses, pay for the expenses. More than 50% of them. After making the the cancer out-of-pocket expenses, we can see the additional 13.9% of cancer patient households fall below the poverty line. Now they are becoming poverty after making the cancer out-of-pocket payment. With the final is 66% altogether in the state of poverty, meaning that we have 13.9% additional cancer patient households becoming poverty, but in addition to that, there are 52.1% is already in the poverty. After making the cancer out-of-pocket expenses, they are pushed further down into a hardcore poverty. Right, so next is the catastrophic expenditure. So earlier on, I have mentioned that in average, cancer patient household used up about 31% of their available resources to pay for their cancer-related expenses. And we can see at a different catastrophic threshold level, we can see that 70.2% of the households are experiencing catastrophic at 10%, followed by 53% or catastrophe at 25% threshold, and at 40% threshold, they were 38.4% households experiencing catastrophic. All right, so next we want to know how the PKB40 incentives, the CCTI and TI, could either help alleviate the cancer patient's financial burden. So these are the summary. We have calculated the average, the cost savings that patient could have. So for CCTI, a maximum of 1,000 ringgit. This is just hypothetically tested. So we assuming all the cancer patients in our study getting the CCTI up to 1,000 ringgit, so they might save 1,000 ringgit from their out-of-pocket expenses. But this excluding the transportation cost, because we have different calculation for transportation cost or transport incentive. So for CCTI, they could save at least 80% of their total out-of-pocket, excluding the transportation cost. For the transport incentive, so Peninsula Malaysia, the average cost saving is about 29.5%, which translates to about 433 ringgit. Whereas for Sabah and Sarawak is about 35.1% cost savings, which translates to around 790 ringgit. So we look closely to this plot. So we can see that only 93 out of 430 study participants in this study had out-of-pocket expenses below 1,000 ringgit, meaning that If they had below 1,000 ringgit, means CCTI could cover 100%, but about close to 80% still have more than 1,000 ringgit. So we can see that still many of the cancer patients have out-of-pocket expenses over 1,000 ringgit from what CCTI can give. In terms of the transport incentive, so first in Peninsular Malaysia, 26.5% of the cancer patients in Peninsular Malaysia can benefit up to 500 ringgit, meaning that covered 100%, but 70% still have to spend on their transportation cost. And finally, for the Sabah and Sarawak, out of 132 cancer patients in Sabah and Sarawak in this study, so 54 of them had a transport cost below 1,000 ringgit, means can be 100% covered by the transport incentive under this program. All right, so we come towards the end of this study presentation, so bear with me, we have at least 2 slides more. So in terms of the, because this study aligned with the criteria set by the PKB 40 program for the patient's eligibility, so this study creates some limitations. So first of all, the study findings could not be generalized to a wider cancer patients in Malaysia. And the second one, because the nature of this study, we collected information retrospectively from the cancer patients, which could subject to recall bias. So either the study findings can be underestimate and overestimate. And finally, because we are unable to include the productivity loss of the caregivers, because most of the interviews caregivers wasn't there, so the final total financial burden can also be underestimated from the study. And finally, these are the take-home message. So first of all, the cost of having cancer, we can see that it is substantial and put an extreme burden on patients and their families. Ultimately could lead to a financial catastrophe and poverty. So while treatments are highly subsidized by the government, cancer patients could still experience a financial burden and remain significant. And also you can see that patient expenditure can be a barrier for them to get a successful treatment and the final health outcome. So with that, I end this presentation. I welcome any feedback and suggestions. Please drop a line to my email, or also this is just a promotion to my Center of Health Economics Research. We are open for any collaborations in health economics research. So drop us a line to our email, chair@MOH. And also, if you are within NIH complex, just drop by or reach us at IHSR Block B2, Level 7 and 8. With that, I thank you.
All right. Thank you, Doctor, for your insightful sharing. I must congratulate you for your completion of your study, and your finding is extremely, I think it's an important findings that we can share to our public, our cancer patients, or even their family members. So this is actually an important study. I must congratulate you and your team for your hard work and hardship you went through all during your the conduct of your study. All right. Since we have a little bit of time, so I may now open the floor for a Q&A session. For those who just joined us, you can register yourself at the link provided in the description section. And if you have any questions, also key in your question in the link provided also in the link in the description section. And then our certificate of attendance will be emailed to all viewers within a week after this session. All right. We have a few questions online from our viewers.
All right.
For the kickstart, okay. During the conduct of the study, what was the biggest problem for you and your team that you need to face? You know, you conduct your study during our COVID-19 peak era.
Yeah.
So what is the biggest challenge to you?
All right. First of all, thank you for that question. So, yeah, it was a challenge for us, for me and the team, because it was a COVID time, and then we have to interview the cancer patients, and then we have to bear whatever the strict guidelines provided by the hospitals, because we need to enter the ward, for example, and then we have to put like a few meters away from the cancer patients, and it's hard for us because some of the cancer patients could not hear clearly.
Yes.
So we have to repeat again and again, and sometimes we used a translator just for the patients to get the right question from us. Yeah. So and again, because as I mentioned earlier, that we had conducted the pilot study earlier on. So the pilot study is actually a savior for us. It was a smooth sailing journey for the large scale study. So yeah. Other than that, all the study sites are very helpful. They are cooperated very well, even from the early to get the approval to get into the facilities as well. So they are very helpful. So I think
That
that's all.
was the biggest challenge.
Yeah.
All right. Okay, I may now open the floor. Now, the first question from our international viewer.
Okay.
Ms. Tiarakmi Yuniarti from Indonesia. Thank you for watching us last time and today. You are our regular viewers. Okay, so question from her. How to get understanding of the patient on cancer illness, on the treatment of their health, on their own body, and also their psychological on mental health.
All right, thank you for that question. So maybe I'm misunderstanding of the question is not a clinical one, right? So if you asking this from the
Clinical.
to get the illness from the cancer patient perspective, there are various approach or methods that you can use. Using either qualitative or quantitative approach. For example, if you are using qualitative approach, you can straight away either using IDI methods. So obviously you need to have a set of questions to probe the cancer patients about their illness, the physiology, as well as the mental health. But for the quantitative, you can either use the you can check their quality of life of the cancer patients using the EQ5D5L questionnaire. It is publicly available. You can just Google online. So in that questionnaire, there are I think 5 domains which include the discomfort, mobility, and so on. So you can just check through it. So that could be my suggestion.
Okay. Yeah. Okay, next question from Dr. Hamizan. Assalamualaikum. Waalaikumsalam. Adakah data-data daripada case mix turut diguna pakai di dalam kajian ini? Case mix mempunyai costing data collection seperti OOP, out of pocket, daripada setiap hospital. Okay, komen doktor.
Alright, terima kasih Dr. Hamizan. Okay, so in this study memang kita tidak menggunakan data daripada case mix. So apa yang saya faham, di mana data case mix adalah data daripada provider side, di mana yang saya tahu ialah diorang mempunyai data inpatient, which is daripada provider perspektif. Tapi untuk kajian ini adalah kajian dari perspektif pesakit kanser sendiri. Jadi approach kita adalah kita menemu bual cancer patient, dan daripada situ kita untuk mengetahui lebih lanjut berapa jumlah pembelajaran yang dibuat oleh pesakit kanser sendiri. Ya, itu yang saya tahu. Tapi betul, out of pocket, saya rasa daripada Malaysian National Health Accounts, diorang ada mengeluarkan out of pocket expenditure, tetapi itu adalah dari provider perspektif. Ya.
Okay. Next question daripada Puan Nurliza Kamaruzaman. Is there any plans to make studies on cancer involving the B40 group so that they can get treatment for free during the study?
So sorry, but the question
is there any plans to make studies on cancer involving the B40 group so that they can get treatment for free during the study?
So, all right, yeah, thank you for the question. It's actually this study is actually only covers the B40 population. So we only take into account the bottom for PK B40 program was meant for the B40 population. But to get free treatment, I think that's beyond me. I'm doing research to get the expenses made by cancer patients.
I can understand from this question is like, if you as a participant for the study, can I get the treatment if I enter the study as a participant, the treatment for free? In other words,
exactly, it's a no. I don't. That's not possible because so we are doing research. We are to get more to get to know more how much they spend. But getting treatment for free if they are be part as the participants. That's not possible, but there were honorarium were given for the cancer patients because they consented to be interviewed by us.
So you guys giving them the honorarium?
It's very small amount, but they are very happy to
for
receive
their cooperation.
the honorarium. Yeah.
All right. Next question from Dr. Marhaini. Great study by DPI. Thank you. In your opinion, how much an adequate incentive amount based on current living cost living in order to ease their financial hardship upon cancer treatment? Did you get the question?
Yeah. Thank you. Actually, she's my colleague.
Yes.
So yeah, thank you, Nani. It's a great point because even indirectly, this study is to show that for policymakers how much actually cancer patients face to pay for their cancer treatment, and about the incentive given. Is it enough or not? It is actually beyond me. It's true that previously we had conducted a qualitative study by asking cancer patients how about the amount of the incentive given, either it is enough or not. So obviously it's not enough, but it is depends on how much resources that we have, and we are doing our best to provide the benefits to all the cancer patients in the B40 at least. So having more incentive is good enough so that we can cover more than 18% of the CCT I can provide now. But to what extent I can't answer that. So it depends on our policymakers or stakeholders and depends on how much budget do we receive from our government. Yeah.
All right. I actually have a personal question running on my mind right now. Okay. Let's be like a general public and put aside your role as a PI for this study. Okay. I want to ask for your personal opinion. Let's say for cancer patients, they already have to face the burden on the financial part. Okay. Do you personally think that the policy, the initiative, the alternative that has been introduced by the government keeps on changing, so the patients need to adopt and adapt to whatever alternative that has been introduced so far? So do you think the adaptation itself is a burden to the patient? What do you think?
A great one.
Yes.
It's actually not a new phenomena, I think. Because it's back to our behavior, the human behavior. Because some of us might think that whatever government could support or provide to us is in front of us, so you can just know everything in front of us. For example, spoon feed by your family members whatsoever. But then, because there are two, what can I say? The awareness itself, get to know something, is far from the current culture of our. I can say that the culture of our Malaysian. Not getting to know whatever the new interventions or simply as financial aids available or provided for them. For example, actually in each hospitals there are the social support department whereby they are dealing with the those unafford to pay for the treatment, for example, and then they actually help the patients to get the aids. For example, for cancer patients, if they go to the social healthcare worker department, so this department can actually interview and then help you to channel you to get the financial, for example, from Magna for cancer patients. So that's how it should be. So I can also think that the communication between the patients and the
service provider,
treating doctors are not going well because it is burden for doctors to tell everything to the cancer patients, but the patient itself, have to do something, ask the doctors, ask your surroundings and so on.
All right. So from your findings, is there any policy has been changed or action has been taken so far by the stakeholders?
At the current moment, I don't think there is, but they are noted about the study findings. But we are.
Are we expecting any policy change?
Not
at this stage.
Not exactly. We are hoping, but expecting to become a reality very soon. I'm not sure, but I hope something that this study findings could help is maybe they can revisiting the incentive given from the PKB40 program.
No doubt CCTI and TI does help them a lot, I think, right? In their at least reduce their burden in certain way. Right, next question. In terms of accessibility to treatment, what did patient felt about this? Did they opted to delay their treatment or even skip their treatment because of not only to financial burden but also by constraint in accessibility to the treatment?
So by right, the accessibility is one of the problem encountered by our patients. Not only in Peninsula, for example, we have a case in Sabah and Sarawak whereby they are living very far at the rural location. So it's kind of hard for them to make a trip just to go to the nearest facilities, hospital. In terms of the accessibility, is still a room for improvement by our government in order to aid for patients to get into the facilities to get the treatment. So one of the barrier that has been actually published in many studies is the accessibility. So even if we ask the patient's perspective, the accessibility is one of the barrier.
All right. Next question from Mr. Kurudevan. Okay, he praised you. Good study. First question. Were the subject more aware of their finance situations, actual costs and incentive, and health prioritization? Did it take long time for them to get aid for their financial protection? First question. And second question, were there any subjects for oral cancer?
All right. So the first question, so as I mentioned earlier, because cancer patients themselves are not aware of the expenses they have to make. but they might be aware about the medical bills because, for example, after they coming for chemotherapy at the outpatient department, they are straight away pay for the expense for that treatment. But in terms of the hidden additional costs that I mentioned earlier about the transport, the parking, some of them were aware, but some of them just, just find resources, just find money, just pay. I want to get a treatment, so that's it.
Second question, would there any subject for oral cancer?
Oral cancer. Unfortunately, no. We don't have anyone, I think, for oral cancer in our study because this is a convenient sampling. So during the interview day, we just whoever are eligible, then they straight away participate in this study. So yeah, no for
None
oral
of them.
cancer. Yeah.
Okay. Next question from Amy. To what extent have the policymakers used evidence from this study to describe on the future health financing for cancer patients, especially the V40 group?
I think similar to what Eliana has asked before. So yeah, at this moment, we are still hoping that policymakers may do something using this evidence provided by this study, and our expectation is, they can, revisit again the incentive given under the PKB40 program, or else if they are planning, not only the government, if there are any NGOs out there planning for a new financial support program for cancer patients in the for the B40 population, they can use these findings as a basis or a reference points to make an estimate how much actually they can help. Yeah.
All right. So I'm afraid we are, running out of time. So last question, what is your take-home message for today?
All right. So yeah, just be aware that cancer is not just a small thing. It's a big thing.
It's common nowadays.
Yeah, not only for you, not only for cancer patients. The surrounding, they need a great support system. In terms of health economics, the cost of cancer is, enormous. So yeah, we have to, I'm not. Yeah, they are dealing with a serious.
That's wrap everything up for today. Before we end the session, I have a quick announcement to make. We have a good news for all our viewers today. Let's celebrate the 5th anniversary of the National Institute of Health Setia Alam in conjunction with Shah Alam Hari Tanpa Kenderaan October 2024 edition, with the theme of Hari Penyelidikan Kesihatan by participating in the Spinal Muscular Atrophy SMA Run 2024 that will be held at Dataran Kemerdekaan, Section 14, Shah Alam on the 13th October 2024. So you may scan the QR code later to register and have the privilege to collect our customized medal with limited editions of t-shirts, cash prizes and exciting lucky draws are awaiting for you. So don't miss this opportunity to participate in the SMA Run 2024. Kain kebaya di dalam peti, jemput hadir di event kami. Till now, till we meet again. Bye-bye.